while there are times when a diagnosis is straightforward and can be made and treatment can be started, for many, many of you, it has been a long, drawn-out process, and that one of the needs is that are there additional kinds of parameters or features that might allow for making a diagnosis more easily and more directly, for staging in a more refined way, for being able to chart the response of a particular lesion or of all of the disease itself more easily. And then also, at the same time, if there is progression, is there a way to become aware of it sooner so that some of the newer therapies can be implemented more quickly, and hopefully by doing that in a faster way, eliminate some of the symptoms and signs and some of the discomfort that that you have to go through before you move to another kind of treatment. This clinical pathological correlation, in which the pathology was primarily being based on the morphology of the skin biopsy or of the blood smear as seen by a trained pathologist looking through a microscope. We heard a lot more about particular molecular markers that people were beginning to explore that might provide an additional dimension or an additional parameter that could also instruct as to what was going on in the fundamental biology of the tumor, but also be used as a means of earlier or more facile identification of the tumor and of being able then to follow it. And in that regard, the issue of clonality came up in the question and answers. And in fact, that's exactly what one hopes for in consideration of one of these biomarkers. You saw that diagram where starting from the single cell and then there were multiple hits and multiple mutations. But if you could identify a specific marker for that cell that first takes that first step toward a malignancy, then and follow that along, then when you looked through the microscope or when you did an analysis, you would find that that one marker, which is specific to that transformed cell, would be present and would sort of declare what was going on as a frank clonal malignancy. Clonality, monoclonality being a marker of, in general, a malignant process, polyclonality being more a marker of a reactive process where you are getting a number of different cells, each one with its own specific marker brought into the area. So I'm going to be describing one particular kind of biomarker that adds value in that regard. My own background is I'm a pediatric oncologist. I spent about 20 years at the National Cancer Institute in the genetics branch, and then left to join a pharmaceutical company, Amgen, doing drug development, and about 4 years ago moved to a spin-out of the Fred Hutchinson Cancer Center, Adaptive Biotechnologies, which is investing in the development of molecular diagnostics, particularly as applied to this one specific kind of marker. And in order to describe it, we have to take a step back and think a little bit more about something that's already been mentioned, which is the immune system. An amazing system which allows us to be able to respond to the myriad of infectious diseases or other kinds of stimuli with which we might or might not come in contact in our lives. The fact is, we living in Seattle or New York are exposed to, certain kinds of infections or allergens or whatever, if we moved and went to some, other place, we might be exposed to a overlapping but also a different repertoire of those things, yet we'd be able to respond to those as well. How is it possible that we have that capability of being able to respond to so many things, some of which we may never actually see in our lifetime? And the way that we're able to do that is a unique feature of our immune response, which again, the adaptive immune response is a function of those same two cells, our B cells and our T cells, which elaborate particular kinds of recognition molecules. For the B cells shown here, it's an immunoglobulin which can sit on the surface of the B cell but also be secreted by that B cell, and which will recognize things that exist outside of cells, bacteria, okay, or other kinds of things that, in other words, are not within the cell itself, and can recognize those things, bind them, and eliminate them. For T cells, there is an analogous kind of molecule called the T cell receptor, and in a very analogous kind of way, it recognizes something that is foreign to the individual, him or herself, but it looks more into those things that are inside the cells. And these immunoglobulins in this case, or T cell receptors in the case of the T cell, are actually formed within our genomic DNA, okay? And the reason why we're capable of responding to this myriad of antigens, and here you see a more schematic cartoon of the T cell, one of the T cell receptor loci, is because there are within each lymphocyte that is capable of seeing this, that, or some other kind of agent, pathogen or whatever, there is a unique rearrangement of the DNA within that cell such that that DNA is now reconfigured so that it recognizes that and only that antigen. In a different cell, it's configured in a different way to recognize something different. Okay. And so those unique rearrangements of the DNA is what confers the capability on the immune system to recognize all of these many, many, many different things, some of which we may not even see in our lifetime. Now, Dr. Vermeer had made the point that in one of his slides that, well, there's genetics and all the DNA in our body is essentially the same. Well, that is true, except for lymphocytes. Lymphocytes start off here, and this is just a schematic showing this part of the DNA that contains the T cell receptor, okay, locus. And initially, it looks like the DNA for that locus in every other cell in the body, in our liver cell or in our heart cells or whatever. But because it's a lymphocyte, it changes at a certain point in its development, and from that point on, it doesn't look like any other cell in the body. That DNA is no longer the same as that of any other cell in the body, nor is it the same as any other lymphocyte which has undergone, again, this strange but miraculous DNA breakage and rejoining event in order to create a specific receptor which uniquely recognizes one or another different kind of pathogen or antigen. Now, you could view that process as it's like a barcode that is unique for every one of those lymphocytes that has undergone that rearrangement. So your body, when you look at your lymphocytes and you look at that, it's like looking at a series of different barcodes, where each of these different barcodes corresponds to a different lymphocyte. And if you were to say, how many barcodes are we capable of generating? Trillions. So it's an amazing system. Now, the assay that I'm going to be describing to you is an assay which essentially is capable of identifying each barcode in any given sample. So if I have 1,000 lymphocytes in a sample, and if they're all different, I can sequence those lymphocytes at the level of the DNA, look at the actual, here you see numbers, but if I were doing it in DNA, it would be a primary nucleotide sequence, A, G, T, T, A, G, A, et cetera, et cetera. And each one of those sequences would be different. So I sequence, I have the sample, maybe it's a blood sample, maybe it's DNA that I've extracted from a skin biopsy that has some normal skin cells in it, but also has lymphocytes in it. I sequence all of that DNA. If there are 1,000 different lymphocytes in that blood sample or in that skin, I see 1,000 different sequences. Okay? So the number of unique sequences corresponds to the number of different lymphocytes. T cells if I'm looking at T cell receptors, B cells if I'm looking at immunoglobulin genes in that sample. But the number of times I see any one of those sequences corresponds to the size of the clone, you mentioned clone, the size of the clone that carries that sequence. Because once that lymphocyte has undergone that rearrangement, it can proliferate. It may not proliferate, but if it sees why would it expand? What would cause it to expand? Well, it could, if you go and you get a flu shot, now it's going to expand, or a series will expand. Not every T cell in the body will expand, but those that recognize one or another components of that vaccine will expand. So those clones that carry recognition signals for that flu shot will expand, while those that don't recognize the flu vaccine won't. What other things could cause a lymphocyte to expand? Transformation. Because a malignant transformation event causes dysregulated growth. Again, that cell was just doing its thing with regard to rearranging its DNA in order to recognize this, that, or the other thing, but something else happened. That something else that happened caused that cell to engage now or to be impervious to normal growth regulation and so to expand. You're looking at the T cell receptor, which is unique to that cell, or the immunoglobulin, which is unique to that B cell, but it has now expanded, and because it's expanded, you can recognize it as having moved beyond, above, the signal from that particular DNA sequence is now much greater than that of all of the other lymphocytes that were present in that sample. So you have been able, using this particular kind of biomarker, a DNA sequence for a T cell receptor or an immunoglobulin gene, to identify the clonal expansion of a specific T or B cell. And that ability is relevant both to diagnostics, as I'm about to show you. It's actually relevant to any situation where there's a lymphocyte, whether that be oncology, where you're looking at leukemia, or myeloma, or non-Hodgkin's lymphoma, including cutaneous T-cell lymphoma. Or if you are looking at a population and saying who's gotten a flu vaccine, who's been exposed to this infectious agent, et cetera, you're looking at the entire repertoire and seeing how it changes, and that can also be relevant. Now, how does it actually occur in practice? You get a particular sample, you extract DNA from it, you look at all of the lymphocytes that are present in that particular sample. In that particular sample, you sequence them all. You then get a bunch of sequences where, again, the number of unique sequences corresponds to the diversity of different cells, and the number of times you see any given sequence corresponds to the clonality of that particular sample. And if there is, again, we do not make a diagnosis in the same, again, already the stage was set, and Dr. Robeson made that very clear. This is not a standalone test. Dr. Robeson was talking about morphologic pathology. I would characterize this as molecular pathology, and it is additional information that then can go to a physician who is looking at your history, what your presentation was, if you have been getting followed over a series of times, what the course of that, what your course has been like during the time that you have been followed, what the biopsy looks like when you look at it under the microscope, and is there molecular evidence of a clonal proliferation? Well, it's a bunch of lymphocytes, and I can even tell you it's a bunch of T cells, but I can't tell you whether they're all the same, they all stem from the same cell, as opposed to just all being there because a whole bunch of different ones went into that, area to fight off this infection or to do something else. This kind of analysis can provide additional information that can instruct in that regard. So here's an example of how that might work, and this is work that was done with the Dana-Farber Cancer Institute. You're about to hear from Dr. O'Malley, who was part of the team that did this. Also Rachel Clark and Tom Cupper, who are involved with the dermatology group at the Dana-Farber. And here, what was done was that a series of different skin biopsies were looked at. And there were some that, because of course, history, presentation, et cetera, were believed to be very, very likely mycosis fungoides. Most of these are mycosis fungoides and not Sézary syndrome patients. And then there was another series of samples that represented eczema or atopic dermatitis or psoriasis or some normal skin samples. And what was done was that from each one of those, DNA was extracted and subjected to this kind of T cell receptor repertoire profiling. And what you see in this example is that those samples that came from patients with cutaneous T cell lymphoma, on the y-axis here, that's the size of the clone that carries a specific T cell receptor sequence. And on this x-axis are just the different patients, okay? And I think what you can appreciate, and maybe it's shown more easily here in this bar graph, is that the patients who have cutaneous T cell lymphoma have a higher level. Their clonality is higher compared to the clonality of all of the other skin biopsies that were analyzed. In other words, they were more monoclonal, okay? So this is looking at, this is, the measure here is a fraction of a given sequence of all of the cells that were present in that sample. The higher the fraction that is comprised by a lymphocyte that has a specific unique sequence, the more monoclonal that lymphocyte population is. The more monoclonal that lymphocyte population is, the more likely it is to represent a clonal population that has expanded because of a transformation event, as opposed to a reactive process, again, where you're going to get many, many different sequences because many, many different lymphocytes. Under the microscope, it all looks like T cells. Okay. So this is a basic, what's called a clonality assessment. Okay. And this is now used, this has gained traction already in some centers, again, not as a standalone test, but as an aid in the diagnosis of patients who have skin dyscrasias that could be psoriasis or could be atopic dermatitis, but could be mycosis fungoides, okay? And by doing this kind of analysis, it aids in, it's another bit of information that might make one trend toward thinking, as again, as Dr. Robson said, you have a molecular parameter, you have a clinical parameter, you have that morphologic parameter. If all three are consistent, well, then you know for sure. If 2 out of 3, gee, you're sort of thinking it is very likely, and if all 3 are equivocal, well, maybe you need to get additional biopsies or whatever. Now, let me just point out, as also was already indicated, this isn't perfect. You can see in these blue dots here, these are samples from patients with psoriasis. Well, you know, if you were to draw the line of demarcation here and say, look, everything above that line, which by the way is where a single lymphocyte comprises more than 1 in 1,000 of all of the cells in the specimen, okay, is made up of a cell with one and only one sequence. You would catch all of those mycosis fungoides samples, but there would be these 3 samples that are above that line as well, which as far as people knew, at least at the time, represented patients with psoriasis. So not perfect, okay, but an aid and pretty good if you look at that separation, and it turns out that it can be of some value. Okay, so you have this clonality assessment. By the way, there are other kinds of techniques that are very much like this that are already used, other ways of determining clonality, one of which is just to look at sequences, but not at the primary sequence level, but just at the size, and that's called TCR-PCR, and that's used commonly. Many of you may have had something like that done on some of your biopsies. Polymerase chain reaction, yeah. I can, if you want, we can talk about that. But it's another method of looking at clonality. But again, at the Dana-Farber study, some of the samples had both techniques done. And it turns out that this sequencing technique is better because all of these black dots that you see there on that graph were graphs that were negative for defining clonality by that prior TCR-PCR, but which we could define clonality or this increased clonality based on the primary sequencing assay. Now, having identified that clone and having identified a specific sequence that corresponds to that malignancy. So now I've got a unique marker. Okay, it's this sequence. It's AAGATT, et cetera, et cetera, et cetera, as opposed to any other sequence that there might be, okay? Now that I have that, I can follow that cell with exquisite sensitivity. So I can identify that cell now if it's within a sample at 1 in a million, or 1 in 10 million if I look at 10 million cells. So it gives me a way of tracking that particular cell, which is essentially tracking that malignancy either from one site to another or over time in a patient who is getting a particular kind of therapy. And here's an example of a patient with Sézary syndrome who at diagnosis, the dominant sequence, the clonal population, was identified, and then underwent a complicated course of therapy, many different kinds of therapy, antibody-drug conjugates, some chemotherapy, transplant, etc. And you can follow the course of that clone, which is essentially monitoring the progress of that patient and how that patient is responding to different therapies by doing this kind of assay where the clone starts off high and then it drops and then it begins to rise again, but then some other therapy is instituted and it begins to drop, and then some other therapy is instituted and then it drops down to 0, and then a few months later it's back, but it's back at a vanishing, at a very, very, very low level. So it gives you an exquisite means by which you can actually track disease in a skin biopsy or in a blood sample over time in response to some sort of therapeutic intervention or multiple therapeutic interventions. It also provides a means of comparing all of the samples on a given patient in a slightly different way. Here you see multiple skin biopsies which were obtained over the past 2 years at various time points. And you can say, well, early on there was, there were 2 sequences seen. Both of those sequences are occurring within the same cell. They're both unique to that cell. You can follow them both. Now, what I've described for T cell receptors and immunoglobulins, again, I can do because it is a unique marker of the malignant cell. There may be other markers, and we heard about a whole variety of them, which people are currently working on, which are not immunoglobulin or T cell receptors, but may also be specific to the MF cell or the Sézary cell that could also be tracked, and that would be variations on a theme of what I've described to you so far today. But I think the basic principles will still hold. And again, the hope is that by combining this kind of molecular pathology with the morphologic pathology, with the clinical impression, that some of the, that we will be able to make diagnoses more quickly with less difficulty, and follow patients, also to stage patients more easily, and then to follow them as they go through their course of therapies with newer therapies in a more efficacious and refined way.